Thank you, Dr. Shanmugam. We straight away go with the first speaker. It is about painful diabetic neuropathy, one of the most distressing complications of diabetes. Dr. Periyandavar will tell us about it. Dr. Periyandavar?
Respected chairpersons, respected teachers, Professor Shesya sir, Sundaram sir, Venkatraman sir, Madhavan sir, Dr. Rajendran sir. Good morning to all of you. It's my great pleasure in sharing this topic, this practice-oriented topic, breaking the pain cycle in diabetic neuropathy. And at the outset, I thank the scientific committee for giving me this opportunity. And there is no conflict of interest. It's a purely academic presentation. And this will be my flow of talk. For this talk, though we have been teaching these various modalities of management of diabetic peripheral neuropathy with painful neuropathy, I have referred the latest updates from ADA 2025 and International Association for Study of Pain, which has their motto, giving chronic pain the greater attention. This year's their theme of them. And of course, RSSDA 2022 guidelines and ICMR guidelines 2080. And it will be a purely academic. To introduce this topic, diabetic neuropathy are a heterogeneous group of disorders with a diverse clinical manifestation. So every patient will present with a different form of diabetic neuropathy, peripheral neuropathy, painful neuropathy, symmetric neuropathy, asymmetric neuropathy, like that. So it's a diverse thing. And coming to the prevalence of neuropathy, it's varied. So in type 1 diabetic patients, the symptomatic polyneuropathy is 54%, and neuropathy impairment scale, abnormal tests are with the 15%. Whereas in type 2 diabetic patient, the symptomatic polyneuropathy is little lesser, only 45%. Coming to the prevalence in India, there's high prevalence of diabetic peripheral neuropathy in India, varied from 9% in some studies to maximum 64% in some of the studies. And for any diabetic patient, the chances of getting diabetic neuropathy is almost 99% or 95%. Based on this, look at this study. As the duration of diabetes goes up, I think the pointer is not working. So if less than 5 years duration, the incidence is less, odds ratio is only 1. If the duration is between 6 to 10 years, the odds ratio increases. 11 to 15 years, odds ratio further increases. And if it is more than 15 years of duration of diabetes, almost odds ratio is 8.03, and all the patients develop some form of diabetic peripheral neuropathy. This is the sad thing. And coming to the classification, it's a very old classification, diffuse and focal. And the diffuse distal symmetric sensory motor neuropathy, this is by far common. Of course, we come across then and there focal mononeuropathies, entrapment neuropathies, truncal neuropathy, like that. The IASP, diabetic peripheral neuropathy, there are many classifications were available. But for the pain, only one association, that is International Association for Study of Pain, they give this as a classification. Neuropathic pain classified into peripheral neuropathic pain and central neuropathic pain. Peripheral neuropathic pain is a pain caused by lesion or disease of peripheral somatosensory nervous system. The pathophysiological classification of pain will come like this: central sensitization, dysfunctional pain, neuropathic pain, peripheral and central neuropathic pain, nociceptive pain like somatic and visceral pain. Coming to the etiological factors, for the painful neuropathy, we have hyperglycemia, hypertension and metabolic syndrome put together all. And for the painless neuropathy, hyperglycemia, greater height, male gender, smoking, alcohol, everything contributes to the development of neuropathy. And when you look at any patients with neuropathy, you should look into non-diabetic causes like toxins, like alcohol, neurotoxic medications like neuropathy, even that anti-tuberculous medicine producing neuropathy, vitamin B12 deficiency, hypothyroidism, kidney disease, malignancies, multiple myeloma, bronchogenic carcinoma, and infections like HIV, chronic inflammatory demyelinating neuropathy, and vasculitis. To the pathophysiology, you should know about this. This is a very old teaching. These 4 important pathways we used to teach for all our students. One is polyol pathway, and second is hexosamine pathway, third is protein kinase C pathway, and fourth is advanced glycation end product, that is AGE pathway. So all these 4 pathways, this AGE and polyol pathway, everything, ultimately they act through oxidative stress, endothelial dysfunction, diminished capillary blood flow, and increased nerve dysfunction and damage, ultimately leading on to nerve regeneration and repair. Similarly, the neuropathic pain, the peripheral neuron hyperexcitability is the main cause, and the central neuron hyperexcitability is the other important cause, ultimately leading on to neuropathic pain. Coming to the screening. So, ADA advises for all type 2 diabetic patients should be screened for diabetic neuropathy at the time of detection itself, and in type 1 diabetic patients after 5 years after detection. Coming to the clinical features. So, if it is acute and chronic, there are 2 features, and acute pain is produced by various causes like truncal neuropathy, cachectic neuropathy, insulin neuritis, painful third cranial palsy, like that. Any acute condition is easy to treat, it will be reversible. Whereas the chronic pain of more than 6 months duration, it's predominantly due to distal symmetrical painful sensorimotor polyneuropathies and sometimes entrapment neuropathies. These are very difficult to treat, and with any form of treatment, patient will get very little improvement. And these are the presentations of sensorimotor polyneuropathy: burning, superficial pain, defective thermal sensation, intact deep tendon reflexes, like that. And truncal polyneuropathy is very rare, whereas the truncal radiculopathy is very common with the acute onset of pain. Clinical presentation, all the diabetic painful neuropathy, they will have typical like this: electric shock like shooting, burning, numbness, tingling, and we should be alert for common verbal descriptors for neuropathic pain, because different patients give different symptoms. Coming to the differential diagnosis of this painful neuropathy: claudication, radiculopathy, Charcot's neuroarthropathy, plantar fasciitis, tarsal tunnel syndrome, osteoarthritis. Basically, diabetic neuropathy is a small fiber disease, and there are a lot of unmet needs and issues. This is an interrelationship between neuropathic pain, sleep, and anxiety and depression. So the pain producing sleep disturbance, ultimately leading on to anxiety, depression, which versus pain, it's a typical triad of diabetic neuropathic pain. And the sleep disturbances contributes to the pain. It's a vicious cycle with sleep disorder and chronic pain maintaining and augmenting each other. Coming to the diagnosis. Diagnosis, first thing is history taking. That is very, very important. Like our first clinical students, we used to teach this inspection, percussion, auscultation, palpation, like that. So for diabetic peripheral neuropathy, 3L things. One is listen, look, and locate. So that we have to, by clinical examination itself, we should clinch the diagnosis. Of course, these are the diagnostic aids for small function, fiber function, pinprick, temperature sensation, large fiber function, lower extremity reflexes, vibration perception, and 10 grams monofilament nerve conduction studies, and rare tests are skin biopsy, corneal confocal microscopy, OCT, and pseudoscan. Coming to the very important topic of management. So first thing we should aim at is good glycemic control, blood pressure control, dyslipidemia management, obesity management, and the cessation of smoking and alcohol. Then only we should go for the medical therapy. And radiculopathy and clinical cranial neuropathies are reversible, whereas sensory motor symmetrical polyneuropathy is progressive, usually irreversible. And this guideline is taken from Mayo Clinical Practice recommendation. So for any treatment of diabetic painful neuropathy, first goal should be 50% pain relief. That is realistic, at least 50%. And the secondary goal is other things like mood elevation, improving quality of life, improving the functional capacity of the patient, improving the sleep, everything we should contribute. Of course, underlying cause which I have mentioned, alcoholism should be stopped and vitamin B12 deficiency should be corrected, and other nutritional deficiencies like vitamin D deficiency should be corrected. And coming to the main topic, that is drug management. This is what we have been teaching for so many years. We have been using in our practice. There are 4 major groups. One is tricyclic antidepressants, and SSRIs, serotonin reuptake inhibitor, anti-epileptic drugs, sodium channel blockers. So the TCAs are amitriptyline, nortriptyline, very effective, but side effects are there. SSRIs, least side effects, but not so effective like TCAs. And of course, anti-epileptic drugs, gabapentin, pregabalin, which are being used very extensively now. Sodium channel blocker, the carbamazepine, which was a few decades back, that was the only molecule available for our diabetic painful neuropathy. Of course, the same 4 classes of drugs have been approved by US FDA and as well as American Academy of Neurology. The same SNRIs, anti-convulsion drugs, anti-epileptic drugs, and the long-acting opioid, terpentrol, tramadol, oxycodone, and the sodium channel blockers like carbamazepine. And other specific pharmacological treatment for this diabetic peripheral neuropathy are ARIs, that is aldose reductase inhibitor, which are studied are alrestat, trolrestat, zinarestat, ranirestat, like that. And nowadays the epalrestat is very popular now. It's being used for our diabetic peripheral neuropathy. And of course, other targeting that pathophysiological pathway, the PKCB inhibitors, the ruboxystatin, and advanced glycation end product inhibitors, aminoguanidine, and of course some treatments were available targeting the myoinositol pathway, but it was not so useful. Gangliosides have been also in the use. These are the second line of drugs which are used for the diabetic neuropathic pain. The alpha lipoic acid antioxidant effect, these VEGF growth factors, but these are paradoxical, and ACE inhibitors, calcium channel blockers, everything has been used. And for the topical application of capsaicin, lidocaine, ISDN, and GT and the patch, and intravenous lidocaine, which also modifies sodium channel expression, and normal saline infusion, which we have been used in our decades back in our department. It was mooted by our professor Dr. Seshaya. We used to do for type 1 diabetic patient, chronic type 1 diabetic patients, those who have severe painful neuropathy. We will admit them for 3 or 4 days. We take for first 2 days we will control glycemic level. Then daily we will give 1 or 2 pints, 75 ml or 100 ml or 50 ml of normal saline. So various mechanisms have been postulated by our professors. So normal saline infusion, it improves the neuronal entry of sodium into the nerves, and thereby improving the reversing the pathophysiological factors. And of course transcutaneous nerve stimulation also have been studied in many studies. And what do ADA says about this thing? ADA strongly recommends capsaicin, has received FDA approval, and patch, capsaicin patch is in use. 8% patch is available, and lidocaine 5% plaster or patch is also available, but has limited data. And ADA strongly disagrees with opioids, because though opioids give good relief, tramadol, tapentadol, they should not be used for neuropathic pain for the potential side effects like long-term side effects like abuse, drug abuse, addiction, fracture, heart attacks, motor vehicle accidents, overdose, and mortality. These are the same words taken from ADA guidelines. And several, the non-specific treatments for diabetic painful neuropathy are this icosapentaenoic acid, that is antioxidant, or GLA, gamma levulinic acid, at a high dose, 480 milligrams of gamma levulinic acid, or 600 to 1200 milligrams of icosapentaenoic acid, and alpha lipoic acid, ALA, 600 to what our common B complex preparations contain only 100 or 200 milligrams of alpha lipoic acid, but studies have confirmed more than 600 to 1200 mg of alpha lipoic acid. And neurotrophins and fentanyl buccal tablets are also available for the thing. And non-pharmacological treatment for diabetic painful neuropathy are neural blockade. This is very popular in the popularly done with the pain clinics. They do sympathetic blocks, sympathectomy, neurolytic techniques, alcohol or phenol neurolysis, pulse radio frequency, and simulatory techniques like electrical spinal cord stimulation, peripheral nerve stimulation using TENS, and electromotive therapy, PEMF therapy, and of course acupuncture in some patients. So only a few words about insulin neuritis. After starting insulin in all our chronic diabetic patients, those who are having high hyperglycemia, so after starting insulin, patient will get acute painful neuropathy, occurs 1 month after insulin OHA, and this is due to rapid glycemic control. The mechanism is nerves in these patients are under general hypoxia and use glucose under anaerobic conditions. Once you treat that hyperglycemia, then that nerves will suffer from relative hypoglycemia, and that is the reason for your acute severe pain, insulin neuritis. So the typical pain will be burning pain, paresthesia, allodynia with nocturnal exacerbation, and depression is a very common feature because we will be convincing the patient to take insulin. But the patient getting severe neuropathy after starting insulin, definitely patient will have depression, and sensory loss is mild. Complete resolution is possible with after 6 months to 1 year. To conclude, diabetic neuropathy is a multifactorial complication, and every neuropathic patient is a teacher for all of us. Everyone gives different experience to us, and barring few cases, there are no effective or preventive casual treatment, and ultimately all diabetic patients acquire some form of neuropathic involvement, as I have shown in one of the studies. After 15 years of duration of diabetes, patient will get some form of neuropathy, and holistic teamwork approach with good glycemic control is the need of the hour. And of course the ADA and other guidelines, they recommend initial combination therapy rather than giving a monotherapy and go on step care therapy, use combination therapy. With this I conclude my talk. Thanks for patient listening.
Thank you.
Our next topic is targeting muscle health in diabetes, emerging evidence and strategies. Though muscle is one of the central organs in the pathophysiology of diabetes, its importance has been realized earlier. Now it is realized, and let us listen to Dr. Bala Murugan, how it translates into metabolic benefits and other benefits with respect to the patient's outcome.
Good morning, everyone. Thank you, Dr. Shanta and Dr. Madhavan sir, and respected my senior professors and the DAISICON Scientific Committee for the opportunity. And another 15 minutes I'll be taking this topic on targeting the muscle health in diabetes. What are the emerging evidences and strategies? So start with an introduction and role of muscle on glucose, and talk about impact of diabetes on muscle and role of insulin resistance, muscle mass, strength and function, how to assess, and what is the interrelation between glucose and protein metabolism, and what is the role of inflammation and oxidative stress, and what are the muscle fiber type alteration which takes place, and what is the role of mitochondrial dysfunction and satellite cell impairment, and what are the current treatment strategies and pipeline treatment option, and summing up. Can you see the difference between the normal and the abnormal muscle? You can see on the left hand side, how is the muscle in diabetes? Okay, the wasted muscle. So this is what the muscle status in diabetes. The skeletal muscle is the main target of insulin and the largest organ that utilizes blood glucose, almost 80%. Skeletal muscle accounts for approximately 40% of the total body weight and it's one of the most dynamic and plastic tissues of the human body. Skeletal muscle and diabetes have bidirectional relationship impacting each other. What is the impact of diabetes on muscle? One is the lower muscle mass, abnormal lipid deposition, slow to fast fiber type transition, fiber atrophy, lower capillarization, and again contractile dysfunction, and impaired mitochondrial respiration, abnormal mitochondrial morphology, increased mitochondrial reactive oxygen. If you look at your mitochondria itself, so many things are happening. What does it lead to? Lower skeletal muscle strength, exercise intolerance, and in fact it leads to increased mortality also. The muscle mass and strength, the physical inactivity, disease-related malnutrition, aging and anabolic resistance, obesity and long-term complication, they all can be part and parcel of hyperglycemia and type 2 diabetes. On the one hand, type 2 diabetes leads to hyperglycemia, and which can lead to skeletal muscle atrophy. On the other hand, skeletal muscle atrophy also to some extent can contribute to diabetes. And the key center here is the insulin resistance, which can cause type 2 diabetes, again skeletal muscle atrophy. And so what is the role of inflammation and oxidative stress? If you look at the diabetes, CKD, and all these things, there is inflammation which leads to the oxidative stress, and through the intracellular reduction in the P13K and mTOR pathway, there is decreased protein synthesis and muscle atrophy. And look at the oxidative stress through the FOXO, it acts and causes increased proteolysis. Again, the inflammation can act through the NFK beta and can lead to the increased proteolysis. And this is muscle fiber composition alteration, type 1 and type 2 fiber. See, in type 2 diabetes, what happens? You can see the two pictures. In type 2, the diabetes, the type 1 muscle fiber is reduced and there is increase in the type 2 muscle fiber. So, this alteration happens leading to the weakness. This is the muscle fiber alteration which I have explained to you, and you can see you look at the cytosolic GRP, more amount, almost it contributes to almost here 69% the GBE compared to the healthy type 2 skeletal muscle fiber. This is the alteration which takes place. And what happens to the mitochondria? Whenever there is type 2 diabetes, inflammation, drug-induced toxicity, comorbidities, and unhealthy lifestyle, and cardiovascular disease, what does it causes a change in the mitochondria? Reduction in the ATP production, reduction in the bioenergetics and biogenesis, which leads to the increase in oxidative stress and ROS production, mitochondrial dynamics alteration, that is a fission and fusion, again the auto and mitophagy and apoptosis. So does it help in the approaching therapeutics? Yes. One, physical therapy, mitochondrial targeted therapy, and the PGC1 alpha via transfection and mitochondrial transplantation. So what happens to the muscle regeneration in diabetes? So there is a failure to regenerate, impaired regeneration of the muscle in diabetes leads to the diabetic myopathy. These through the various signaling pathways like Notch, WNT signaling, and mTOR pathway, and ENT ADAK signaling axis. And what is happening in the stellate cell? There is impairment of the stellate cell. You can look at the activity of the stellate cell. The physical activity will promote more healthy stellate cell and the diabetes will be doing against it. So this alteration in the stellate cell, again, what is the net result of diabetes on skeletal muscle? The net result through various pathways like AGEs, insulin resistance, mitochondrial dysfunction, and intramyocellular lipids, inflammation, ROS, all these things what has caused metabolic dysfunction and atrophy of the skeletal muscle. So how do we clinically diagnose sarcopenia? Three main criteria. One is low muscle strength, low muscle quantity, and low physical performance. Alone, criteria 1 is considered the most reliable and should guide towards the diagnosis of sarcopenia. When combined, criteria 1 and 2 account for the certainty of the diagnosis. If you have all the three, it means sarcopenia is considered to be severe and based on the link between the low physical performance and poor prognosis. How do we assess? There are screening tools available. Screening the SARC-F questionnaire more than or equal to 4 indicates risk. Strength, very simple things. I talked about complicated things in mitochondria, and now I am telling you what simple things to assess in the clinics. The strength hand grip dynamometer, 5 times sit to stand test. Can all of you just sit and stand for a 30 seconds? How fast can you just do that? In 30 seconds, how many you are doing? How many times you are able to sit and stand? Yeah, please sit down. Okay. And the 5 times sit to stand test is very, very simple test to assess how is your proximal muscles. Again, the performance, the gait speed, short physical performance, battery, and 6 minutes walk test. These are all simple bed test tests everybody can do. We don't need a big complicated test. And the body composition, if you have to do, DEXA scan, gold standard, and we have BAA is a practical alternative. What is emerging on it? Ultrasound for muscle thickness and quality. Balance test, side by side standing test, semi-tandem stand and tandem stand. How do we assess? Strength, assistance in walking, rise from a chair, climb stairs, falls. If you are getting the score, the scores are available in the net itself. You can see if this is 0, none ability, and if it's 2 or more, it means the severity of your muscle weakness is more. And this is an upper limb assessment. How to assess? There's a hand grip strength, which is easily accessible with this machine. This is how we assess the lower limb strength assessment and muscle mass assessment. We can do using the dual X-ray absorptiometry and bioelectrical impedance analysis. And this is a bioelectrical impedance analysis scale. What are the goals of therapy? Improves the muscle strength, power and mass, enhances mobility, balance and coordination, reduces the risk of falls and fractures, maintains impedance, improves cardiovascular health and quality of life. If a person is able to walk and he does the things by himself after the age of 70 years, no, it's really good. He takes care of himself. So the muscle health is very, very important to at least to take care of your needs, not to depend upon others. So this is the outcome measures. How do we measure the strength, grip strength and function, gait speed, sit to stand, balance, Berg balance scale, quality of life, there's a questionnaire available, and reassess every 6 to weeks for the progression. And how do we manage it? Quality of food, highly nutritious, more protein based food is better than the more fat and glycemic food. And adequate, multiple amino acids regulate the insulin sensitivity and skeletal muscle. Adiponectin helps and thyroxine helps. Here you can see the branch chain amino acids, mainly the leucine, isoleucine, and as well as arginine and methionine, all helps improving in the glucose utilization, increasing the protein synthesis, and so better glycemic control and reduce insulin resistance. Talk about sleep. People don't know why. We are sleeping every day. What is important in the sleep? So what happens? Many a time we see at 12 o'clock in the midnight, most of our people are in the WhatsApp online, many people are not sleeping. So good quality of sleep is very, very important, not only the quantity. So this is a main issue, not only ours, many times doctors also work as a shift workers. So the shift workers, it's a real problem. There can be altered light exposure and altered feeding patterns, which can lead to the muscle protein balance. Again, it also changes the food habits. The potential mechanism is change in the appetite regulating hormones, changes the food reward areas of the brain. So what happens? Increased snacking, reduced protein intake, and comparatively they do more carbohydrate. So what are the current treatment strategies for the improving the muscle health? Exercise is the current, which is the predominant one. What are the difference mechanism? The GDF15, irisin mechanism, IL-6 based, myonectin, myostatin, all these things, mostly they increase the lipolysis, increase the fatty acid oxidation, and increase the fat browning. These are all the various mechanisms by which it improves the insulin resistance. Again, how do we go with the exercise? Start slow, progress slowly. Combine resistance plus aerobic plus balance training for maximal benefits. Supervision is very, very important. Long-term maintenance programs are more effective than the short-term intervention. The resistance exercise is a form of active exercise in which muscular contraction is resisted by an outside force. So it improves the power, strength and endurance. Many times we do only aerobic exercise, we don't resistance exercise. After 40, 50, everybody must do the resistance exercise at least twice a week. And these are various gadgets available. Dumbbells, barbell rod and weight plates. And this is the choice of equipment you can decide for the weight measurements. And the resistance training is very, very important, I already said. So exercise already more than 150 minutes of the moderate intensity or more than 75 minutes per week of vigorous exercise. And these are the various types of exercise you must do. Why I am talking much on exercise is right now there are not much of drugs presently available to improve it. So exercise is very, very important. and these various exercises. So coming to the drugs, exercise also increases the GLP-1 secretion, which again can cause a reduction in the food intake, improve the insulin resistance, improve the glycemia, and improve your muscle health. And what are the various pharmacological intervention? The insulin, GLP-1 analogs and DPP-4 inhibitors can have better beneficial effect. And again, metformin, SGLT2 inhibitors and thiazolidinediones can also have a better beneficial effect. These are the mechanisms potentially contributes to sarcopenia that might be amendable to modification with drugs used to treat diabetes. So one, insulin resistance, drugs can address that. On mitochondrial dysfunction, drugs can address that. And oxidative stress, autophagy, microvascular endothelial dysfunction, and chronic inflammation, AGE cross-linking, and altered microbiome, intramuscular lipid accumulation, all these things are addressed by few of the drugs which are already available in the market, and these are the list of the drugs which are the benefit. Again, insulin, increase the protein synthesis in the muscle, sulfonylurea and glanides, inhibiting the ATP sensitive potassium channels and increasing the caspase 3 activity in the skeletal muscle. Metformin again increasing the AMP K-alpha 2 activity in skeletal muscle, inhibiting mTOR. Thiazolidinediones activating the PPR gamma, decreasing the muscle lipid content and increasing the muscular mass, inducing oxidative stress. The GLP-1 analogs, increasing insulin secretion, decreasing the loss of fat-free mass, decreasing the protein degradation. These are all the various benefits. What is vitamin K2? What does it do? Alleviates the insulin resistance in skeletal muscle by improving the mitochondrial function. So the vitamin K2 improves the insulin resistance by improving the mitochondrial function. And what are the pipeline treatment options? Mitochondrial transplantation. So improve skeletal muscle strength and sarcopenia by my dear friends, but you should remember right now the limited data only is available in type 2 diabetes. In the time to come we will get to know more, and what is called as hexa protein improves the skeletal muscle insulin resistance. This is done in animal trials, seems to be promising, we need to wait and see. Again, the myodN, muscle forming oligo-DNA, binds to target protein nucleolin in myoblasts and improves the differentiation of myoblasts. Seems to be promising. Thank you very much, and we'll take up any questions.
Thank you, Dr. Murugan. Dr. Balamurugan, excellent presentation of the bidirectional relationship between diabetes and the muscle health, and how targeting the muscle health translates into clinical and metabolic benefits. And thanks for also highlighting us on the latest developments in the field of muscle health. Thank you.
We take up the question at the end of the session. Yeah. Now I invite Dr. Manoj Chawla to talk to us about clearing the air around inhaled insulin.
Morning everyone, and pleasure being here. Dr. Shanmugam and Team DAI for having me here. We heard some wonderful conversations, including the last one on diabetes and muscle health. My job is to clear the air around inhaled insulin. Very interesting topic to this particular subject. I am contracted by Cipla, which is going to be getting Afrezza in the coming month to India. But there are a lot of questions in mind when we hear about it, and I'm going to try and clear that in the next 14 minutes or so. So that's the discussion, the way it's structured about insulin, how it has evolved, the presence now of inhaled insulin, how it's different from the previous one, what really is this inhaled insulin, what's the evidence, and then concluding with some aspects of practical means of using it and where to use it and where not. So insulin, as we know, has been a century-old wonder. The evolution of insulin has been tremendous. We've moved from animal insulins to DNA, recombinant human insulin availability. The pharmacokinetics have also evolved from the intermediate acting to long actings and then the ultra long acting insulins. The prandial insulins have evolved from the regular animal insulins to human insulins to the rapid acting analogs and now the ultra rapid acting analogs. Also, when you look at the means of administration, the comfort has changed from the reusable injectable syringes. I see many seniors here who would be well aware of how in the past patients would boil their syringes and then use that. We moved to disposable injectable syringes and then the dial-up pens, which changed the scenario for insulin. And then of course the insulin pumps from the earlier insulin pumps, continuous subcutaneous insulin infusion, to the current AID systems. And all this progress, one aspect which has continued to be common is the fact that insulin has remained an invasive route of administration. We still have to inject. And the holy grail that all of us have been looking for is a non-injectable means of using insulin. The two aspects that have been looked at is oral form of insulin. Well, still a dream, a lot of work being done in that area, but hasn't seen any success. And then it is, of course, a means of inhaling insulin. So the journey of inhaled insulin is also interesting, and it's not very, very new. The concept of inhaled insulin goes back almost 100 years in 1925. In 1971, Wigley and colleagues administered the first aerosolized insulin via a nebulizer to the rabbits. Somehow, rabbits and insulin have had a very strong history. I'm sure all of you are aware that the first time the description of hypoglycemia happened by James Collip, it was because of administration of this product into a rabbit. And that was the first description of actually the phenomenon of hypoglycemia, when the rabbit injected that impure extract in the early days, went into a convulsion because of hypoglycemia. That's how they discovered hypoglycemia. Also, one of the viva questions that all examiners here very often may be using is, how do you really define 1 unit of insulin? So your 1 unit of insulin is defined as a particular aspect in pertaining to rabbits. So, cutting the trivia short, rabbits and insulin have had a very, very interesting journey. In 2006, the US FDA approved Exubera, which was an inhaled insulin developed by Pfizer. Many of us here got to see the device and had some of the initial meetings and advisory boards back then. It was to be made available to us in 15 days. And at that time, unfortunately, it was withdrawn in the US by Pfizer because of logistic and financial reasons. In 2014, almost 11 years back, the US FDA approved Afrezza, which was an inhaled insulin developed by Mankind Corporation. In 2018, Cipla collaborated with Mankind, and this is Mankind US, not the Mankind here. And then in 2024, Cipla received the approval for distribution and marketing of Afrezza in India. So let's understand what this insulin is. It's the only inhaled insulin available for use. It's a rapid-acting inhaled insulin indicated to improve glycemic control in adults with diabetes. So as of now, the approval is only for adults. Approved by US FDA on 27 June 2014 and has been commercially available in the US since 2015. It's formulated using a technosphere technology using which the insulin gets adsorbed onto certain carrier particles. These are 2 carrier particles, which is fumarate diketopiperazine and polysorbate 80. This combination, it's a compact inhaler. These 2 products actually make insulin get absorbed very rapidly through the pulmonary system. So you have rapid acting insulin, but for it in a puff to get absorbed is where these 2 carrier molecules help this doing the job. Now, they are available in 3 different units of cartridges, and I'll come to that. So this is the technosphere technology. You have microparticles, the FDKP, which I mentioned, which comes in contact with regular human insulin, Afrezza here, and normally stored at a pH of less than 6. The moment it comes in touch with the natural pH, which is above 6, of course, in the pulmonary system, the inhaled particles dissolve rapidly and separate. The FDKP and insulin are then quickly adsorbed across the lung membrane. So that's the technology which gets referred to as technosphere technology. Now, what's the evidence for this kind of an insulin? Let me take you through some of the important data here. So this is the earlier studies in healthy subjects looking at the pharmacological profile. T1 here refers to technosphere insulin, which demonstrated quicker onset versus other rapid acting analogs. So here they have compared technosphere to Lispro, which is Humalog or whatever name, and as you can clearly appreciate the much rapid absorption of insulin in the pharmacodynamic as well as the pharmacokinetic profile. For comparison, it's showing you the time to measurable effect with endogenous insulin is about 10 minutes. For Afrezza, it's 12, whereas any of your rapid-acting insulins is still 15 to 30 minutes. The time to peak effect for Afrezza is similar to endogenous insulin, and time for effect to return to baseline is far more rapid as compared to even endogenous insulin, let alone any of the commercially available products. Let's look at its clinical efficacy in type 2 diabetes. Significant A1C reduction when added in type 2 patients uncontrolled on oral drugs. These are, of course, placebo-controlled data. Then on top of OADs, on one arm you have placebo and on the other arm you have technosphere insulin. You get a 0.82% reduction in the insulin arm as compared to a 0.42 where placebo was added. Anything which is 0.4 and above is considered significant. You can clearly see the PPG excursions improving in the Afrezza arm as compared to where you had just the placebo, of course. No significant hypoglycemia, no significant difference in severe hypoglycemia. Then you look at the data for type 1 diabetes. Now, type 1 diabetes, of course, unlike the type 2 study where on top of OHAs you've added placebo and insulin, for type 1, these are patients who are already on insulin. They're doing their own basal bolus therapy. So you have a comparator here. You have Afrezza in one arm and you have another short-acting insulin analog. So it wouldn't be ethical not to give insulin to type 1 patients. So let's understand the difference between a type 2 and a type 1 study. Here you're seeing that from baseline to the end of the study in the aspart arm, on top of existing standard of care, you saw a 0.4% reduction in aspart. In the Afrezza arm, you see a 0.21. But the fact that the difference between any standard of therapy and Afrezza is less than 0.4, this was a difference of 0.2, gives it an equivalent, a non-inferiority of Afrezza to aspart. In terms of hypoglycemia, in the Afrezza arm, you see some lesser hypoglycemia and similarly lesser severe hypoglycemia for Afrezza as compared to aspart. What about the side effects? That's the question. Well, cough is going to be one of the side effects for this technosphere insulin, and that will be the most limiting aspect of its use. There is some amount of throat pain or irritation, and then other side effects seen which were not too different between both the arms, be it headache, diarrhea, fatigue and so on. But cough will continue to be, and some throat pain and irritation. You're looking at the pooled safety population for technosphere insulin. Well, reported in 27% of Afrezza patients versus 5.2% of comparator for the cough. This is overall in its entire data. 9.4% of the cough episodes were characterized as intermittent or single defined episodes, was generally mild, dry, occurred within 10 minutes of inhalation, was transient and declined with continued use. Cough was the most common and will be the most common reason for us discontinuing this drug. 2.8% patients treated with Afrezza discontinued because of cough. So we do expect that as we get this product in our hands. Also, they have an aspect of pulmonary safety. We all, when we start using it, will have to look at the FEV1 for our patients, and anything which is more than 70% would be the need or inclusion criteria or your ability to offer it to your patients. There will be some decline in FEV1. However, this is drug driven. The moment you stop the drug, the FEV1 comes up. So as long as it is not dropping too much, it is fine, and you will be looking at FEV1 6 monthly initially and then yearly later on once you start using the drug. The lung safety with Afrezza has been evaluated for a 2-year study, and changes in FE1, as we can see, that you do expect a small decline, but then it stabilizes. Changes in FE1 were small, occurred early, remained non-progressive up to 2 years, and resolved when the treatment was discontinued. So it's almost similar as we may see with some of the other drugs that we use for GFR decline. We do expect when you use even an SGLT2 or a Finrenone that you do see some GFR decline and then stabilizing. You can expect something similar with FEV1. Overall, what to expect? So when you look at the complete data of clinical trials for FEV1, 1 out of 3 individuals had a small FEV1 decline, which is 0 to 5%. So that's what you expect. There would be some extremes. If there is more than 20% decline in FEV1, you have to stop this drug in that particular patient. But predominant what they've seen is between 0 to 5%. So cough will be an aspect. FEV1 decline is something that we expect. Has it been bothersome? Not so far. So back to the basics of technosphere insulin, Afrezza. Route of administration is oral inhalational, single inhalation per cartridge. to be administered at the beginning of the meal. You're going to get it in 3 different cartridges, which is very simple to load on the device, and then just a puff there. 4, 8 and 12. So unlike what we've been conventionally used to, 7 units, 9, 11, 14 units of insulin, there will be some de-learning and learning. It will be in multiples of 4, 8, 12. So if somebody is going to be requiring 10 units of conventional insulin, here you will end up giving 12. You need not worry about that 2 extra units because the absorption is lesser, so the impact is lesser. Otherwise, in a type 1 patient, each unit or 2 can have its own effect on hypoglycemia, but not when you're using inhalational insulin. So you'll start with 4 units before each meal for an insulin naive patient and then step it up. And they have shown you the combinations of how, if somebody is on 9 to 12 units, you will use 12. So you will use a combination of a green and blue, which is 8 plus 4, and so on. So 3 different cartridge combinations is what you can use. Key steps, well, there are different cartridges. Open the package, remove a blister card from the foil package, tear along this foil package, load it onto the inhaler. I'm sure if there is a stall here that Cipla has, they can actually show it to all those who are interested. So you load it onto the cartridge, inhale, and then just open it up and remove the cartridge, and you're ready to use with the next cartridge to be kept on top of it. Indication, it's a rapid-acting inhaled insulin indicated to improve glycemic control in adult patients with diabetes. You have trials undergoing for type 1 in the pediatric population and even in gestational diabetes now, but that is trials underway. They don't have an approval yet. Here also it's for adults with type 2 or type 1. The important limitation of use is in patients with type 1, you have to use it along with a long-acting insulin. Not recommended for treatment of diabetic ketoacidosis and not recommended in smokers. Any history of smoking in the last 6 months, this drug ideally should not be used in those patients. Contraindications, lung-related conditions. So chronic lung disease, asthma, COPD, you will not use it. During episodes of hypoglycemia, of course, you will not use. And any known hypersensitivity to regular human insulin, you will avoid this because essentially it is human insulin adsorbed onto the particles. So finally, things to remember before you initiate Afrezza once you get it. Before initiating Technosphere insulin, necessary to perform a detailed medical history, physical examination and assess the FEV1 to identify potential lung disease in all patients. FEV1 should be more than equal to 70% of the predicted value. Assess FEV1 at baseline and after 6 months and then annually thereafter. If in patients taking Technosphere insulin, FEV1 declines by more than 20% from baseline, consider discontinuing this Technosphere insulin. So with that, let me conclude that Afrezza is the only inhaled insulin approved for use in diabetes. Ultra rapid acting mealtime insulin with a compact inhaler device, found safe and effective in clinical trials with over 3,000 treated patients, often offers proven mealtime glucose control. We had a wonderful talk earlier by Professor Rahul Raj on postprandial hyperglycemia, and this kind of inhaled insulin becomes one another therapeutic option for targeting postprandial hyperglycemia. Prompt reduction of high sugars within 12 minutes. The most common adverse events besides hypoglycemia would be cough and some throat pain or irritation, and it has been approved by our own CDSCO for adult individuals with diabetes mellitus. With that, thank you once again for having me here. Have a wonderful day ahead.
Thank you, Dr. Manoj. It is exciting to know that after almost 2 decades hiatus, we are now started talking about inhaled insulin again. The floor is open for discussion.
What I find missing in the literature is the small piece of data which have been part of in Apollo, which was, I think, by Lilly. We started the inhaler insulin and then it was abandoned because there were safety issues. Now the issue is, when you inhale insulin, probably around 18 to 30% is adequate enough for the hypoglycemic effect. More than 50% gets entrapped in the interstitium. This was associated with some, what shall we say, troubleshooting pulmonary nodules in the, so it was abandoned. In fact, I was the principal investigator. Raj B. Singh, the chest physician, was the co-principal investigator. So we randomized a few patients, unbelievable reduction in the postprandial blood sugar, unbelievable. But one caveat was, since the capsules have to be inhaled through the regular autohaler, only people with asthma we took because they are more used to using this device. So that was one catch. But the efficacy is assured, unbelievable. The postprandial comes down, we had 2, 4 and 6 milligrams at that point of time, and we were able to control the postprandial like anything, but there were some safety issues. In fact, to do that study, Apollo Hospital was funded to buy that DLCO machine, which was costing around 80 lakhs at that time because of the diffusion lung capacity. I think Dr. Shantaram knows about it. I've discussed with him also. So I just wanted to know whether those, obviously it would have been cleared. So, but what I failed to notice is in the literature, the mention about this particular, not because my name was there, but from the literature, this has not been there at all.
So you're referring to the Lilly inhaled insulin, right? So there's been a difference between Exubera from Pfizer and the Lilly's attempt. So Lilly's attempt was even more short-lasted at the inhaled insulin. Pfizer almost, they got their product out. Lilly in its developmental itself stopped. Now, rightly so said that the earlier literature and the information that we had that the absorption is so much poor that you require higher dose of insulin for it to be effective through the inhalational route, and largely a lot of residual insulin remaining in the alveoli, and its impact, whether it's going to be insulin being like an insulin like growth factor, is it going to lead to some chances of malignancy, some other aspects of bronchiectasis and so on. We don't know the reasons. You know, when Pfizer withdrew it, they said it was logistically difficult. The price at which they had to make the device and make it available and the amount of insulin, it would have been impossible for them, and in the US largely driven by insurance companies, for them to ever get insurance to accept, to give this. The only change that I understand, sir, which has happened is with this technosphere technology which has come in, and unlike a conventional inhaler, which is what they're using, this technology with these two particles is allowing the absorption to be much better and not requiring that much higher dose of insulin. Having said that, that little throat pain and cough could still be a symptom of little residual insulin, though it claims that it gets into the circulation real fast because of technosphere and then gets out. So I was a part of the Indian phase 3 trial for this. Of course, in a trial you get 4, 5, 6 patients, and some are on placebo, some are on the drug, so you don't get a complete idea, but didn't really see concerns of cough. In terms of, are there any long-term concerns when you start using this? Probably, but the data coming in from at least Mankind, and what funnily has happened is, even I wondered if it's been around for last 10 years, why aren't we hearing much about it? Now they say that Mankind US is a smaller company, has to find its ground, insurance wasn't supporting it. In the last 2 years, we've started seeing a difference in its presence and data even at the ADN and the technology meet, because its usage is slightly increasing. Some of the insurance companies have started allowing patients to buy this in place of irregular analogs, and which is where the data is coming in. Seems interesting, but having said that, when all of us get it, I think what's important for us also here in India to have certain aspect of pharmacovigilance, irrespective of the data that comes in from the West. When we start using it, we should be vigilant when we use it in our patients to see of any of the concerns.
In fact, I agree with Manoj, and I have been also part of this Avrisa trial. We have almost enrolled 15 patients, and as Professor Venkatraman said, the control, everything is good. And the short term, there was no complication. There was no reduction in the FEV1, the data. But as Manoj said, we need to wait and see what comes on a long term.
Dr. Venkatraman, if you remember correctly, I am subject to correction. The older inhaled insulin, the concentration in the extremely high. That was one of the reasons why they were discontinued. Whereas I am surprised here that for 10 units, you just give 12 units. Probably that is one reason why we are.
Geographical regions, but having said that, one of the places where it's been marketed is the US, which does have reasonable geographical variation and colder temperatures. So they haven't seen that, sir. So I think, as it said, somebody who's not able to use it, and as it said, in an acute emergency, if somebody has hyperglycemia getting into ketosis, ketoacidosis or ketosis, I don't think we should, then you should go always to a traditional. That's what you talk even about somebody on the pump, that somebody's sugar shoots, we don't know if it's blocked or whatever, please take a conventional shot. Is that your question, that somebody's? So during an acute viral, right, so surprisingly, during the trial there were some patients, though we don't have a clear data, it didn't impact. But then again, these are things that when we start using it, we'll have to see whether. they can use the conventional one.
In fact, we do not recommend to patients with the COPD or asthma. This is not absolutely not recommended. We do not. Rangarajan sir, you have some question,
Yes,
please.
yes, sir. The first question is to Periyandavar, sir. As one of the pathophysiological process in the diabetic neuropathy, endoneural vascular supply is compromised.
Yes.
To improve this endovascular dilatation, gamma linolenic acid is very, very helpful, sir. Number one.
Yes. I have mentioned GLA.
GLA,
I have mentioned.
And number two, sir, regarding the neuropathy pain, another one more important cause is spinal canal stenosis. If this patient has got a spinal canal stenosis not been diagnosed through an MRI or something like that, so that will also be one of the precedent factors. We always be thinking diabetic neuropathy is also.
Non-diabetic causes.
So the tests are not required, sir. Basically the clinical, I said, the clinical based test, I explained, clinical, at least 40 plus, sir. For 40 plus hand grip test, it's a very simplest one, and I said this stand-ups and the sitting chest, and these are 6 minutes walk test, at least over 40, sir. Sir, if you are a diabetic, 40 plus, if you are a normal person, at least 50, you have to start. Okay. No, we do not have any data on the calf muscle circumference. Yes.
Sir, for severe diabetic peripheral neuropathy, spinal canal stimulation is one of the best options. That is also there. And to Dr. You said about the muscle wasting, all this. What is the role of nandrolone deconate in improving the muscle mass?
Yeah, the anabolic steroid, there are, in fact, some years back, a decade back itself, anabolic steroids were used to improve the muscle mass, all these things. But the data and the trial data are not very robust on that. That is why I have not mentioned that.
In fact, there should be a little caution about it, especially young individuals. Very often in the past, before you had the wave of the proteins coming in and the wheys and the others, young individuals hitting the gyms very often were told to take, you had your decadurabolins and various other steroids. I don't think it was the safest means of building up the muscle. So, a little bit of...
The wasting of the muscle, because I'm not talking the younger generation. I do agree, sir, all the ill effects. A patient is not able to do it.
So I think today you do have the means, sir, of looking at a bioimpedance or a DEXA where possible, assessing the muscle aspect. If your muscle itself is much lower, then I think we need to have means of improving the muscle and getting whatever possible resistance training at the given age. I'm not in favor of use of any of the anabolic steroids. Sir,
both nutrition as well as the exercise has got a greater role in playing this, sir, apart from improving the insulin resistance and glycemic control. Yes, over to Shanmugam.
International association like American Association of Clinical Endocrinology also discourage using testosterone or
Not testosterone, sir, I'm talking...
anabolic steroids,
Yeah, nandrolone.
including
You said
testosterone for muscle building, for older age group, sarcopenic obesity.
So the limited data available at present, sir, we need to wait. Okay. Then,
Sir, at last, your speech, sir, it was quite an interesting and mind-boggling. And one thing I want to know, whether you had to hold the breath as we are holding the breath, as in the case of, when you're taking inhalers, the other inhalers.
Fortunately, no. The device itself is so small and sleek, it is putting that end into the mouth and that's it. So unlike even a traditional where you're having to hold a breath, this is just a swoosh, if I can say, and no real need of holding the breath and this thing. That technology itself is pushing it way down into the alveoli, so much, much simpler. The larger difficulty that we saw in the trials was asking your patient to do the assessment of the FEV1. So, when you look at patients who do a spirometry post-surgery or whatever, how many of them on day one are able to blow it up to 1500 or 1200? They'll end up starting with that 500, 400 and pushing. So here again, asking patients to assess, I think, is where we're going to have a challenge to make them really do the test right, and all of us will have a lot of learning to do once this becomes available.
we did. In fact, the trial also, we did a lot of, we have taught the patients and made them to feel, and it was a good learning experience, sir. But this technology, as Manoj said, the technosphere, That's really, really very good technology in which reduces your effort comparatively. The patient's effort is less.
I feel teaching pranayama, that is a breathing exercise, before starting this therapy for at least 2 weeks, that will improve the efficacy. That's all.
So what is the youngest age, sir, you can initiate in type 1 diabetes? As you mentioned, it can be used in type 1 diabetes. What is the youngest age you think
Only
you can?
adults, sir. So it's approved, no, it is approved in type 1, but only adults. So
Less
it's
than
not
18?
more than 18, sir. 18 and above is an
No,
adult.
no, less than 18 is not.
It is not approved.
Thank you, sir.
Sir, any experience
Sir.
of Venkatraman, sir? Any buccal
There is
insulin?
just I want to make a
Sometime
comment.
back.
I want to make a comment on Afreeza. So Afreeza has got a better 1 hour postprandial control. Somebody is asking whether it will translate to endothelial benefit 1 hour more than the 2 hours. If that is the case, I think is a larger role to play in future. Afreeza.
Sir, my question is to...
And that is common, sir. Hypothesis always this based on insulin resistance.
Yeah,
But
my
based
question
on
is
the
to-
metabolic parameters we are talking, endothelial, yes sir. See, but between the 2 hour and 1 hour, if the 1 hour control has got a better,
Yeah. Sir,
Sir.
one question
Yeah.
from the floor. Yeah, please.
Sir, my question is to Dr. Balamurugan. What is the role of pre and probiotics in hospitalized patients, rehabilitative patients, and those with comorbidities? That's my first question. And my second question is to Dr. Manoj Chawla. Sir, we know that Indians have a 30% lower lung volume. So in that case, even a normal person will not be able to do a proper FE, I mean the spirometry and all that. So in such a situation, should we advise them to go for any lung diffusion volume studies or any other better studies than doing for FEV1?
I will answer the question. Doctor, you asked about the role of prebiotic and probiotic. And see, today we talk much about what is called gut-brain axis and the role of both the microbiota as well as the probiotic. They all have suppose basically today diabetes is looked into a disease of inflammation. So all these, obesity, when you look at the gut microbiota, they got a favorable effect. If you're having a favorable gut microbiota, it is going to have a favorable effect in terms of reducing your insulin resistance, reducing your obesity, reducing your inflammation. So these things are really into work, and at present there is a lot of research is also on, and in the time to come we'll try to get more data on that.
So quickly, we very often use the term pre and probiotic as one common term. Well, we need to also understand probiotics are essentially your gut helpful, healthy microbiota which has all the benefits that Dr. Balamurugan said. Prebiotics are substances which help the probiotics work. So whether it's fiber or other substances. So pre and probiotic as a term, you will actually have probiotics, but you need to also look at, if you're looking at commercial products, which have some prebiotics which make your probiotic work better. To your other question, well, I think this has been validated across the studies, and which is why FEV1, even in the Indian studies, they've looked at FEV1 and FEVC, but FEV1 becomes the standard mark. On a conversation with the pulmonologist, if you ask, no, that's probably not true, that largely the Indian population will have a lower lung capacity. But I agree with the point that assessing and doing the test can be a challenge because we are not used to it. So that's a challenge that we foresee, but that will still be the standard test because all the data is based on FEV1, so we can't assess some other lung function test.
Thank you, sir. I think that's the end of it. We'll
Yes.
congratulate all the three speakers, sir. Thank you.